Good afternoon and welcome to the September 11th meeting of the Health Policy Committee. I'd like to turn it over to our Executive Director, David Seltzer, as brief announcement.
Hi, good afternoon, everyone, commissioners, members of the public, those of you joined by our online webcasting. Welcome back. I hope everyone had a very nice and restful summer because we have a very, very busy fall ahead of us. Beginning today with, I think, a real powerhouse meeting of new research and new data on topics of real critical importance to the healthcare system here in Massachusetts. But before we dive into the meeting today, I wanted to acknowledge the regrettable absence of our board chair, Dr. Stuart Altman. And I wanted to quickly share some information about that. I've been in touch with Dr. Altman and his family, and they wanted me to share that Dr. Altman wishes he could be here, but that he is in the process of recovering from some health issues, and he will be back as soon as he can. I think on behalf of all of us, we're sending our support and well wishes to Stuart as he recovers, and we look forward to having him back in the office soon. But with his temporary absence, however, that does bring us to the first agenda item here today, and I'm going to turn it over to Undersecretary Peters to tee this up.
Sure. Thank you, David. So since Wendy's departure, we have not yet appointed a vice chair to the board. And given the important role of this position and the governance and leadership of the HPC, I'd like to propose today that we take a vote to appoint a vice chair. And I think we have a great choice among us. Marty Cohen has been with the commission for about 5 years and has really been our behavioral health expert and has helped lead the subcommittee here. And so on behalf of the secretary, I'd like to make a motion today to appoint Marty Cohen as vice chair of the board.
I'd also like to second this. As I just want to note one thing, which is a feature shared by Stuart and Wendy and Marty Cohen, which is they have, of course, opinions, which they express strongly, but in a way of moving us forward and helping us have discussion. And I think that's been one of the hallmarks of the chairs of our meetings, is that they're not afraid to speak, but what they absolutely do not do is drown out. That is, they're encouraging us in our discussion. And I noticed that very strongly among Marty, as we all tried to do as commissioners. So I'm delighted to be in support of this.
I appreciate the vote of confidence from my fellow commissioners, although I will say I anxiously await Chairman Altman's return to the center of the seat. And I think I join with all the commissioners in wishing Stuart a speedy recovery and would return to his rightful place here. But with that, so the first item of, I guess the second item of business is the approval of our minutes of July 24th, 2019. And I have a motion to approve the minutes. So, any changes, deletions, additions? Hearing none, all those in favor? So we'll now move into our full agenda, which we have some very interesting information to share, some research that's been done by the commission. We'll start with the market oversight and transparency report and transparency, and I'll turn it back over to David to tee that up.
Great, thank you, Mr. Mr. Vice Chair, and while I do not have a vote in this matter, I also am very supportive of you taking on this role. So on behalf of all the staff, look forward to working with you. As I mentioned, we have a real wealth of new data and research and information to share with you and the public today. I'm thrilled and really proud of the team and the staff who spent many months working really hard to refine some of the analyses and data that we're going to be able to share today. And I think in sum total provide really new insights into the functioning of our healthcare system, some of the pressures and trends that we're observing, and really hope today that we can use our time to engage you in a conversation about both where we can take this analysis moving forward, and also around your questions and thoughts and feedback as we begin to prepare for the cost trends hearings, because I do think a lot of the themes and topics that we'll touch on today will be very pertinent for those two-day hearings, October 22nd and October 23rd. Register online today. And so I want to use today's meeting really as an opportunity to tee up some of those big themes and questions so that we can have a really fruitful and engaging cost trends hearings next month. So with that, I'm going to turn it over to the team today, and we'll start with our regular agenda item on our material change notices, but then move into some of our brand new material.
Thank you, David. So since 2013, the Health Policy Commission has received notice of 105 provider transactions, with physician affiliations and clinical affiliations the most frequent, followed closely by hospital affiliations. The HPC has 2 notices currently under review: a proposed partnership between Bay State Health System and AmSurg Holdings to jointly acquire AmSurg's 62% ownership of Pioneer Valley Surgicenter, an ambulatory surgery center in Springfield, and the proposed acquisition of Exeter Health Resources, a health system in southern New Hampshire, by Partners Healthcare. Since the last board meeting, we elected not to proceed to a CMIR for 2 transactions. First, the proposed contracting affiliation between Sturdy Memorial Associates and South Shore Physician Hospital Organization, under which Sturdy providers would participate in risk contracts negotiated through South Shore PHO, and South Shore PHO would provide medical management support services for Sturdy providers. When we examined relative price and spending data for the parties, we found that South Shore PHO is somewhat higher priced than Sturdy, but that spending for South Shore's patients is lower than spending for Sturdy's patients. We did not review evidence indicating that the transaction is likely to negatively impact clinical quality or access to care. Second, the HPC elected not to proceed to a CMIR for the proposed clinical affiliation between Partners Healthcare System and Boston Children's Hospital, under which Brigham and Women's physicians would provide maternity care at a new integrated maternal fetal care center housed on Children's campus. In our preliminary examination, we found limited scope for spending increases due to this transaction. There is some potential for enhanced coordination of services and information sharing between Children's and Brigham specialists. We did not review evidence indicating that the transaction is likely to negatively impact access to care.
Not on these transactions, but David, can you help me out with what our role, if any, would be in a merger between Harvard Pilgrim and Tufts?
Sure. So we do not, under our statute, transaction between a merger of 2 health plans is not something that would be noticed to us for review. If a health plan and a provider system were to merge together, that is something that would be subject to a material change notice in our review process. But our statute does not contemplate mergers between 2 health plans. That will be reviewed by the Division of Insurance, as well as potentially, obviously, the Attorney General's office, and perhaps other federal regulators as well.
Could we, on our own, decide that we were interested enough to analyze it without the requirement by statute to do so?
We have discretion, obviously, to look into issues that impact healthcare spending and healthcare cost growth in the Commonwealth and market functioning. I think we would want to first understand more about what the Division of Insurance's review process would entail and whether there would be a net benefit to the Commonwealth for us to be involved, and maybe a support role for them may be appropriate as well.
Well, if there are no further questions, we will move on to the next agenda item, which we are really excited to preview for the board today. So as you know, one of the HPC's core functions is to continually monitor the structure and functioning of the healthcare provider market. So we conduct this work both through our ongoing receipt and analysis of material change notices, as well as through in-depth research projects, such as the Community Hospitals at a Crossroads report that was published back in 2016. At the last board meeting, we discussed how our team is, in particular at this point, doing some in-depth analyses of some of the past material change notices that we've reviewed, and to assess the impact of those transactions on healthcare costs and market functioning, and the degree to which the parties achieved their stated goals. Today we want to talk to you about another piece of our ongoing work. Here we're doing a comprehensive review of overall provider market trends over the last 5 or so years since the HPC has been in existence. Much of that includes updating and expanding on the analyses that were part of the Community Hospitals at a Crossroads report, and supplementing those analyses with some new analytic tools that we've developed in the intervening years. So we are going to preview some of our initial results of this work. We're really excited. We're tracking toward publishing this in early 2020. And to give you an overview of some of those initial findings, I'm going to turn it over to Sasha Hayes-Resnoff, Senior Manager on the Market Oversight and Transparency team, who is managing much of this work and who is also one of the key analysts and authors of the Community Hospitals at a Crossroads report.
Thank you, Kate. So as Kate mentioned, our look at market-wide trends has drawn heavily on our prior work on the Crossroads report. And in that report, you may remember this graphic highlighting many of the challenges faced by community providers and independent providers in the Commonwealth. And this graphic was intended to illustrate how many of these challenges feed into one another, creating a sort of cycle. And I want to touch on a couple of the findings as prologue to our updates to many of these analyses. So starting from the top right, one of the things that we found was that continued consolidation of providers, both through full corporate merger as well as through expanded contracting affiliations, even clinical affiliations, we're beginning to funnel more referrals into networks and send more care within systems to anchor hospitals, AMCs and teaching hospitals that might have been appropriately provided elsewhere. As more care went to those anchor hospitals, we saw community hospitals frequently had lower commercial volume, and in some cases as a result saw their bargaining power with commercial payers degrade and their relative prices tended to be lower than other hospitals. Lower prices then funneled into an impact on those community providers' financial performance. In many cases, low relative price was correlated with relatively low financial indicator metrics. And that in turn impacts the ability of those providers to make investments for the long term, and in particular innovation programs of the sort that we would like to see in order to control utilization and drive appropriate use of care. And that in turn, the need for resources to invest in those programs then turns those providers back towards thinking about affiliation, which brings us around to the front of the cycle. So those were a few of, high level, a few of the observations that we had in the Crossroads report. Those observations based at that time primarily on 2013-2014 data at the latest. And so now we've begun to use use more recent data to look at the extent to which those challenges that we observed are being addressed, and to what extent we can observe improvement or a lack of change in newer years of data. Unfortunately, our findings have been that, at least initially, the progress in many of these areas has been somewhat limited. As you know, to start with, hospitals have continued to consolidate in the common goal. This graphic here shows the share of hospital volume, inpatient and outpatient, provided by the top 5 hospital systems in Massachusetts since 2010. And so the bars in each case show the top 5 systems, and then the total percentage of the hospital care market is at the top there. And you can see that total share of hospital volume in the top 5 systems grew from 45% in 2010 to 54% in 2017. That's based on 2017 affiliations, and since then we've had additional consolidations that have brought the total volume in the top 5 systems up to 63% based on 2017 volume. That's 18 points market share gain in the top 5 systems since 2010, primarily through hospital consolidation. We are not seeing huge shifts in overall in the number of patients that are choosing system hospitals, but as hospitals have joined those systems, the percentage has increased. And correspondingly, as you look at the orange line there, the upper orange line represents the share of hospital volume that is going to independent community hospitals, and that line has declined by 60 percentage points since 2010.
So what's the independent non-community hospital? What does that mean?
So those are folks who like Dana-Farber, for instance, formerly New England Baptist and Mass Pioneer, although they've consolidated recently. So one of the common rationales offered for consolidation has been that systems are going to better coordinate their patients' care and direct patients to the most appropriate settings. In theory, those efforts should help change the pattern that we observed in the Crossroads report of patients going to AMCs and teaching hospitals for care that they could easily have received safely and effectively in community settings. The newer data that we're using to look at that trend suggests that many patients are continuing to bypass local community options, even for community appropriate services. For this analysis, we focused very specifically on patients that ought to be most amenable to being shifted towards community settings. We're focusing on people who live closest by drive time to a community hospital. Therefore, for example, not looking at folks in Boston who may live closest to one of the downtown AMCs. And also looking specifically in this graph, although we've done a lot of cuts of this, but this graph showing scheduled care, that is folks who are not coming through the ED, non-maternity care, and community appropriate services as defined in our definition of community appropriate discharges, discharges that ought to be able to be performed safely and effectively at most hospitals. And as you can see, the blue bar at the top here are people who live closest to a community hospital, but bypass community hospitals and got that care at a non-community setting, that is a specialty teaching or AMC hospital. And that percentage hasn't decreased over time, despite all of the efforts of providers in our market that are working to direct folks to appropriate sets of care. And I'll note that these utilization patterns have a spending impact. Based on 2016 numbers, commercial spending was about $41 million higher than it would have been if these patients had gone to their local community hospital for this care.
Why did you exclude maternity?
So our understanding is that patient choices for maternity care may be influenced by some factors that are different from other types of care. We have done cuts of this, including maternity care as well, if you're And so this graph zooms out a little bit, showing community hospitals' share of community appropriate discharges over time. The blue line here is all payer discharges, both commercial and public payer. And that line hasn't shifted substantially since 2010. And you can see that the commercial orange line has dropped slightly. Community hospitals are seeing even fewer commercial community appropriate discharges than they had been previously. We're looking forward to incorporating 2018 data in this graph soon, but so far we don't see the community hospitals have been seeing a larger proportion of community appropriate discharges over time. So these, unless there are questions, these data are consistent with our findings in the Crossroads report that community hospitals' inpatient volume has been declining, and that it was declining in particular for commercial patients. Newer data showed these trends continue. Community hospitals are relying increasingly on public payer volume and on outpatient services. This graph here showing changes in volume for inpatient and outpatient services by both all payer and specifically commercial. So the blue bars here. So this is all community hospital changes in volume. The blue bars here are all payer changes in volume. The light blue bar at the top is outpatient services, and you can see community hospitals saw an increase in outpatient services for all payers. The light purple bar there, the upper one, -9%, they are seeing a decrease in commercial outpatient volume and an increase in all payer volume. So the split there being they're seeing more, a larger proportion of non-commercial outpatient volume. And it's a similar story that community hospitals are seeing lower numbers of inpatient discharges as represented by the two darker lines here overall, but they are seeing a larger decrease in commercial inpatient volume than they are a decrease in public payer commercial. All hospitals in the Commonwealth are seeing a shift towards outpatient services and towards public payer services. Community hospitals are seeing a larger shift towards public payer patients than other types of hospitals. Amy, less about with the continuing shift away from commercial volume, community hospitals have continued to see relatively low growth in commercial prices. We've looked at this many times in the past. The HPC, GIA, the AG's office have all reported on the fact that there's a lot of variation in hospital prices. It's worth saying some community hospitals do receive moderate and even high relative prices, but the median community hospital price remains well below the median commercial and teaching hospital relative prices. And we found that lower priced hospitals tend to remain lower priced over time. This graph shows an example of some Blue Cross prices for the highest priced and lowest priced relative priced community hospitals. Sorry, not just community hospitals. Hospitals at the top and bottom of the relative price scale of all types. You see that several of the lower priced hospitals are community hospitals, and they haven't shifted substantially since 2010. And when we looked at the 10 community hospitals with the lowest prices in 2010 across all three payer networks, we saw that most of those hospitals were still in the bottom 10 relative price hospitals in 2017 across all three payer networks. So folks who are at the bottom of the scale here are tending to remain at the bottom of the scale.
What services are in this?
So this is both inpatient and outpatient. This is a blended relative price. As I mentioned in the Crossroads report, we found that the preceding trends, everything we've talked about so far, tended to lead to poorer financial performance for some community hospitals. We we've taken a look at community hospital financial performance over time now, and found that as a group, and particularly for community hospitals that have high proportions of public care patients, those hospitals continue to face some challenges. Again, here, as with relative prices, we're noting that the community hospital cohort is a large cohort and it's pretty well varied. There are some hospitals in the cohort that are doing particularly well by the financial metrics, some that are not as strong. As a group, the numbers for community hospitals don't look dire, and indeed, community hospitals tended to have pretty good operating margins and total margins as compared to statewide averages. But one thing that we did note in particular, and especially again for high public care community hospitals, is that the volume growth and revenue growth for those hospitals tends to be especially soft as compared to statewide averages. And when, even if those hospitals are managing expenses, if they don't have revenue growth to invest in new programs and transformation efforts, that is going to be hurting them long term. They impair their ability to, again, make the sorts of investments that we would like them to make in transformation activities. So, obviously, these challenges aren't occurring in a vacuum. Provider organizations are trying to react to improve their positions in spite of all of these challenges. And one strategy that we observed as we dug into these new analyses, including at community hospitals, is that providers may be trying to focus on their revenue cycle, that is, ensuring that they receive as much revenue as possible for the care that they're providing. And we started to turn up some interesting numbers as we looked at how care is being coded. As we were looking at, in particular, the analysis around community appropriate discharges, we observed that statewide, the proportion of discharges that we recognize as community appropriate has been falling over time. As you can see in this graph, over time across all types of hospitals, a larger proportion of discharges are being coded as higher acuity. Shift is a little bit more pronounced for community hospitals, about 7% drop, as opposed to teaching and AMCs at about 6% apiece. And this begs the question of what's driving this change. Whether, to what extent is this being driven by actual changes in the inpatient acuity, and to what extent is this being driven by other factors like approaches to coding. And our research and cost trends team has been digging into this in many different ways. And we're going to turn the presentation over to them to talk about what they're finding, some outstanding questions that they have, and in this space there are many, always, but they've done some really great initial work and the implications of what we're seeing for the market. So unless there are any questions about.
So we'll pause there before turning it over to some of our colleagues on the research team for questions about this overall market-wide scan, and in particular the updated analyses based on community hospitals at a crossroads.
One question I'd like to see some follow-up on is on the operating margins. It'd be nice to see what they are for all of these hospitals over time and broken down into components. So this gets to whether or not there's a crisis brewing for some, because somewhere between half and 2/3 of the operating margins for many hospitals now are either 340B pharma revenues that are derived from discounted prices they get from the federal government. I'll just stick with that. It would be nice to have that as a component of each one, because if that goes away or if that goes down, operating margins could go from slim to none pretty fast.
Absolutely.
Yeah.
We have that right, don't we, Sasha?
We definitely compile all the operating margins. I'm sure that we can find the breakdown pretty soon.
case suggest that we still have too many hospital beds? If so, by what percentage do we think that hospital inpatient stays would decline over the next, I don't know, 5, 10 years? How much overcapacity is there? So how worried should the commonwealth be that there will be other closures, operational considerations at hospitals, things like that?
That's a great question, and as we think about that, I think we'll also try to think about it in terms of service lines, because as you know, there are some that are underbedded and some that may be overbedded. So we'll do some thinking about that. Great. Do you know more reactions to this? Do you think this does provide, again, a nice platform for some follow-up questions at the cost trends hearings about maybe why we haven't seen as much progress as we'd like, and then what would it really take to break through some of these persistent challenges, especially for high public payer community hospitals that we're seeing some challenges in. So I'm going to ask the next research team to join me at the table here. And for the next part of the presentation, we really wanted to dive in deeper onto this question of the increasing acuity that we're observing of patients across the Commonwealth in the data. And we're going to be looking at this both from what the health plans are reporting to us in risk score growth, and also what we're seeing in terms of how providers are billing for different types of inpatient care. I would say that this topic is one in which we do not have all of the answers, and very want to state that up front. And again, want to use this as an opportunity perhaps to be able to ask questions of providers and health plans at the cost trends hearings. But with that, I'm going to turn it over to David Auerbach, our Director of Research and Cost Trends, to go through this part of the presentation.
Thank you. Yes, this is work in progress that we are going to be presenting more in full in the cost trends report this year and at a future committee meeting as well. We wanted to get some of this for reactions and feedback to direct that future work today. This is work by Dr. Plunkett, who is joining me to my left, and Laura Nasubi behind me. If there are technical questions, some of this does get technical, and I'll try to stay at a fairly high level today. So this is really connecting a few streams of observation that we see throughout our work. One of them is what we just saw, where this decline in community appropriate discharges is just occurring market-wide. They're disappearing. What's going on with that? We also have been seeing this trend that we've talked about before of increases in patient risk scores reported by the payers. Is this all coming from the same thing? And at the same time, an increase in the acuity of inpatient stays that we saw reported on last year. And so I'll first present some kind of big picture trends showing what's going on in all of these areas, and then try to drill down a little bit on the inpatient side, see if we can make more sense of it. Okay. So starting here with what commercial payers are paying for hospital stays. This is a trend from 2013 to 2018, brand new data. And what we're showing is on the top, the amount of total payments from private payers to hospitals over this period of time, $3.57 billion in 2013 to $4.02 billion in 2018, increasing year after year. And below that is the number of commercially paid inpatient stays. It's been declining. So payments have been increasing each year while the number of stays have been decreasing each year. And that wedge is pretty large, and what you get to putting these together is that, as it shows in the blue, the amount paid per discharge rose 5% per year over this time period, from $14,400 per stay to $18,300 per stay by 2018. So that's a 5% annual increase. Now last year, we looked at price trends on the inpatient side of the HPC, and this is for a smaller time window, from 2014 to 2016, where we saw some of this as well. And we noted again that volume was declining while payments were increasing. And we divided that increase in payment into a price effect and an acuity effect. And at the time, it looked like they were both relatively equal contributors to this overall increase in payments. And we didn't know much about what was underneath that acuity, so that's what we're going into a bit more today. So when you see price there, price means price for the exact same stay. And acuity is, are these stays changing? They're becoming more and more complex, at least the way they're coded. Okay, so here's the risk score trend, stepping back, sure. Oh, that's just the CPIU for, I believe, Massachusetts. Okay, so when you look at risk scores for commercial payers, so this is an all-in measure of the health of all the patients that are members of a certain plan. And we look at the largest payers, so this is most of the Massachusetts market. From 2013 to 2017, we would expect this to roughly hover around 0 unless we think there's something dramatic happening in the Massachusetts population overall. And you can see here that they're all going up. And there's variation across the payers, but overall, these risk scores are increasing about 3% per year. And over this period from 2013 to 17, the total increase in patient risk is 11.3%. And that's a significant number. If you look at actuarial tables, for example, an increase that large is something like if you had 413,000 more people, commercially insured people in the state with diabetes with complications, you would see a number like 11.3%, or about 888,000 additional Massachusetts residents with cerebral palsy. That's about the size of what you would expect that effect to be. It doesn't seem plausible.
Does every member get a risk score, or every member should use services?
These are risk scores covering the entire book of membership for these payers in the aggregate.
And they define the risk score.
Well,
they
we'll get
define
into
the
that.
outcome.
It's complicated, but yes. They take providers code the diagnoses, they get run through software, and out pops a risk score by these complicated algorithms and risk adjustment methods.
Go back to Don's question. Something like a third or 40% of the people do not, members generate no claims.
Right. So they're in there, and they'll just have very low risk scores.
Well, no claims means no risk score.
You'll still, there are age and gender factors and other demographic factors that still will be at play.
But there's nothing that's going to adjust it up, right? So they're going to be flat because they've got no claims.
Yeah, those people will be flat. So everybody else is bringing that up.
But this reflects the entire membership.
The entire membership.
But you could conceivably you could construct a risk score only for members that did this.
Right. Which is, I think, is what we want to do. Subtracting out, I mean, just devil's advocate, right? If one of the plans had a 40% rate, another had a 20% rate of no utilization, it would materially affect the number that was in.
But we could check the percent of population with no claims year to year. I don't think it changes that much. It's usually on the order of maybe 20% in the commercial population, but it's a good point. But you do want an all-in measure because what we expect in terms of total cost should be reflective of that total population.
Let's just make sure it's not an outlier from one of the plans.
And just to point out, I don't have the number off the top of my head, but I know that Mass Health has seen very similar trends in our on the healthcare side. So this is not unique or isolated.
David, what do we know about this really significant increase in carbon pillar?
Good question. At this point, I don't want to focus too much on the differences by payer because we haven't looked at it closely. Okay. There could be some shifts of membership across these payers, but I don't think that's all that's going on. Okay, so here's one way to think about that, and one important implication right away. We spend a lot of time thinking about health status adjusted TME because that's a performance measure that's important for tracking the market and for performance improvement plans and so on. So over the same time period, total actual spending growth was 15.8% for the commercial population I just showed. But when you look at health status adjusted TME growth, it's just 4.4%. The vast majority of that actual spending growth is offset or absorbed by this 11% risk score growth. So the end of the day, the HSA TME measure is really picking up more of the HSA than the TME. And that's important as we think about so many things where we track HSA TME. So, I mean, one question we all have is how much of this risk score growth is real health status, or is it coding?
David, I just want to back up just to underline a point on the previous slide. When we have entities that are referred to the Health Policy Commission through the CHIA process, they were referred on their performance on health status adjusted TME. But when we talk about the Commonwealth's performance against the benchmark, we're really talking about total spending. So the unadjusted spending growth of 15.8%, that impacts our ability to hit the benchmark, even if we're only able to look at entities on a health status adjusted TME level, which may be quite much lower than the actual spending, the real dollars that are going out the door. So it does have implications for us in terms of monitoring performance of individual entities as well as the performance of the state, because the unadjusted is important for us as we think about whether or not we're going to meet the benchmark.
So I don't want to get too bogged down here, but to understand the few slides that are coming where we're going to look more closely at the inpatient side, we have to talk a little bit about DRGs and what they are. The DRG is a classification of an inpatient stay, and it's the way that almost all payers, commercial and government, pay for inpatient stays. And there's really two systems that are ongoing, and we're going to show results from both. The MS DRG, which is used by Medicare. All inpatient stays are classified into these about 700 different groups, pneumonia, COPD. And each DRG then has a severity level. Most of them do, without complications, with complications, and with major complications. And the Medicare program and payers pay more for the more complicated versions, logically, to try to reflect the different resources used. There's a different system that most commercial payers in the state use, as well as Mass Health, called the APR DRG system. Same idea, but just slightly different classifications. It's run through a software program. And here you have, every DRG will have 4 severity levels, which I'll be showing. The lowest, level 1, is the least acute and the lowest payment. And you can see on the right an example of how those payments tend to work. This is using an example from Mass Health for COPD. You can see a COPD level 1 stay is $5,000 up to COPD level 4, about $15,000. Those are 2018 levels. And the way these are actually tracked in the data and paid for is there is a weight. There's a weight attached to each level, and the payment is proportional to that weight times some base. So I'll be spending the next few slides tracking trends in that weight, which is the way to get at the overall acuity. First of all, we can track trends in these weights, and this is again talking about just inpatient side by hospital system. And you can see the overall trend here is that they are going up in all hospital systems across the same time period, and here the data is up to 2018. This is what hospitals typically refer to as their case mix index, and it is the weight according to one of these DRG systems. Here's another way to look at these trends. Under the MSDRG system on the left and the APR on the right, you can see the different levels of classification. Let's look at the APR DRG system. You can see that the lowest severity level, and this is similar to what we saw in the community appropriate discharges, most of them are in these lower acuity levels, and that's why we call them community appropriate. Those have been dropping. 20% drop in the lowest severity level. And then on the right, you see an increase in the high severity levels. And this is partly important because we might have thought that, oh, maybe you just have these low acuity discharges, they're moving out of the hospital into outpatient settings, and that explains this acuity increase. It really doesn't look like that's what's happening. That might be to some small extent, but you see the increase of 66,000 discharges in those high acuity levels, even more than the decrease in the low acuity. It really looks like just a shift to higher acuity coding. Okay. And just a little bit of context as to why we think this is happening. This is a known phenomenon. People refer to revenue cycle management, case mix improvement. This is something that hospitals are doing writ large. And it's not a surprise, there are industries and there are consultants who have formed to take advantage of these higher payments and the higher severity levels and the abilities of EHR systems like Epic to mine patients' clinical records, to identify diagnoses that will result in higher payment, and to code those and maximize reimbursement. And for example, hospitals I show in the middle are hiring personnel whose job it is to do this. You have RNs who are paid six-figure salaries, and their job is to identify diagnoses, including conditions, qualifying as major complications that impact severity of illness and other areas of opportunity. And this is just something that's going on. And when we sit in meetings behind closed doors, you hear folks say, you know, it's a lot easier to increase your margin by coding than by actually reducing costs. So that's enough. The ROI from hiring more builders and coders shows no signs of diminishing. Or we even heard a newly hired hospital CEO saying, I'd love to work on care delivery, but my focus has to be on coding maximization. It's just a phenomenon that happens because it pays. Here's another example. We can show a very stark trend in that. We can show this across diseases, but I'm picking on COPD again. On the left are showing the different payment levels for the different levels of a COPD inpatient stay, and then on the right, the trends in the percent that are coded at each severity level. You see, for example, the severity level 4, a payment twice as high as the next highest level. And the percent of inpatient stays coded at level 4 grew from 3% to 12%. Level 3 grew from 37% to 53%. Okay. And we wanted to test, are patients with COPD just sicker? And although you can't say that perfectly definitively, one indicator is, well, do they have a longer length of stay? Are they using more ICU, more CCU days as an indicator of severity? And the answer is no. There's no trend in that. It's even a decrease over this period of time at the same time that the weight has gone up 20% for these patients. We track the same trends for the entire hospital population, and here's the overall effect of this weight increase of 13.9% under the APR system, 10% under the MS system, and again, almost no change in length of stay, and a decline in ICU, CCU days. So that's a bit of what's happening on the hospital side. Something else we've been trying to understand a little better is the payer perspective on this. It seems like if the hospitals are getting paid more, how do the payers feel about this trend? What are they doing to counter that? And they are taking some action. Payers do end up paying more, as we show on the top, when hospitals are reaping higher payments. There are often risk contracts that are tied to the population risk level, where a payer would pay more if the risk is higher. But there are also scenarios where the payers also benefit from higher acuity. So they might have mixed incentives. For example, the Affordable Care Act has a risk adjustment mechanism for those folks insured through the connector, where the payers with the low acuity patients make transfer payments to the payers with the high acuity payments to try to ward off adverse selection. So that results in a big shift of money for the payers that have the sickest patients. If you're involved in Medicare Advantage, you get a payment directly proportional to how sick your members look. And as we've mentioned, if you're a payer and you have an increase in your risk scores, you're less likely to be recommended for a potential performance improvement plan. And we've seen that over and over through the data. So there are a number of implications of this trend. This is partly why we wanted to talk about it today and continue to understand it better. Number one is the added cost. We've done some projecting of the scenarios of what this actually means. For example, if reported patient acuity was the same in 2017 as it had been in 2013, there was no change. Massachusetts would have paid about $280 million less to Medicare, incurred $280 million less than Medicare cost in 2017 alone for inpatient. On the commercial side, it's a little bit murkier because there are some contracts that may offset some of this, and there are some complications in what version of the software the payers use. But it also looks like an effect of roughly a similar magnitude, that $300 million just in 2017. So there's a direct financial cost. This trend can increase disparities across hospitals, as we've seen. Some hospitals have more resources to invest in this activity, and others have less. It creates somewhat of an arms race, and the hospitals, if a payer, let's say, decreases the base rate, then the hospitals that aren't doing this can fall behind relative to the hospitals that are. They can actually lose money. It also importantly affects our accountability metrics. HSA, TME, we've talked about. There are quality metrics, there's readmissions rates, mortality rates. Any quality metric that is adjusted by patient risk or patient acuity is going to reflect this activity as well as the true measure itself. And what's the impact on patient care? There could be effects in different directions. There certainly could be some benefits to having additional diagnoses coded in my record that are relevant to me, but there could be some offsetting trends as well. Sometimes these electronic health records get filled up with everything under the sun that could be coded for a patient. It's hard for clinicians to even find what's the relevant thing right now versus what's all this other stuff I have to sift through. It takes clinician time. We're hiring RNs whose job it is to do this, and they're often pinging the physicians to find out, can I write this down? Is this okay? Is this real? You have time and attention of hospital leaders and administrators focusing on this instead of patient care. And again, our performance measures could be picking up more of this activity than the actual thing they're trying to measure. So these are some of the implications. I'm sure there's more. As I said, we're continuing to try to understand this. Both the market retrospective work that we presented as well as this. There's not only shifts in acuity within a DRG, but we see shifts from one to another. Patients often have symptoms where you can have an overlap. Is this pneumonia? Is this sepsis? Is this? There's often a fuzzy line between what I'm going to call something and what I'm going to call something else with payment implications. And there's a number of other, we haven't talked about mass health today, but we will in the future because there's some more complexity going on there. Okay.
Well, these data are sobering. I know you're going to talk about the cost trends here in the later agenda, but is this something we can have some discussion with industry leaders about the cost trends?
I think it's a great opportunity to engage in a conversation. I think one of the key drivers that we've observed in total healthcare spending has been in the hospital setting. And so one of the thematic themes that I think is worth spending some time on at the cost trend series is in trends in the hospital market and in hospital trends. Both, I think, can reflect some of our earlier work on community hospitals and some of those trends, as well as maybe what both health plans and providers, their perspectives on this. I think that's a great topic for conversation. I would say, in some cases, these are organizations that are acting very rationally, given the incentives that are put in place. And so I think we're trying to understand exactly how those incentives are driving some of this behavior and some of this work.
Is there, you'd think that if it's a coding game mainly, which I think it is, that there'd be a plateau here that you can only go so far with that, but these lines don't seem to be flattening out. Do you have an impression about whether we're...
It's a great question. We keep looking for the plateau and thinking the same thing, and we haven't really seen it. That one quote about the ROI is just one anecdote, but it seems like the ROI is still there. Something we haven't talked about today, though, is that, for example, Mass Health has very recently deliberately adjusted those weights, which makes a lot of sense. If you keep coding less and less sick people into those high categories, eventually you're overpaying in those categories. And you can go back and say, the resource use doesn't really justify that payment anymore. I'm going to compress those weights. And if all payers did that, you might eventually see a plateau. There would be less of a return to that higher level. But we don't see the plateau yet. Is that fair? Maybe in 2018 a little bit, and soon we'll have the full 2018 data. We only had a taste of it so far.
Yeah, and that would be plateau overall for all providers, but there's still some providers who are catching up and some who focus everything they could already. So that could be differences by providers and payers.
As always, we tend to talk about providers without separating providers into hospitals and independent physicians. And we know from other data that the independent groups that take full risk do less, what's the category called, low value testing, I think maybe it was one of the analyses last year. And I would think that we would hear, if we heard from one of them, let's say the cost trend hearing, they, unlike the quotes that you offered from the hospitals CEOs, we probably hear, no, we don't spend any time on it. We're really interested in keeping people healthy and out of the hospital because we have incentives that are perverse. So I wonder, it'd be interesting to look and see where the lines are for some of those other areas like unnecessary testing or low value testing for the groups that are providing it, and to split it into hospital-oriented hospital systems and independent physicians. There's a lot of national data on this. You know, your Medicare ACOs that are IPAs perform at a much higher level, much more cost-effective level, higher quality outcomes than hospital-sponsored ACOs that are of that. So I think we could build on that data as well to see where it fits.
I think that's a great point, and I think would provide a different perspective, perhaps, of the cost trend series to not just have hospitals, but also a physician-led organization. And you know, this does have implications for them as well, because if you're a physician organization that's taking on risk for your members, you're accountable for the hospital spend. And if that hospital spend is going up, that can ding your budget and make you less successful in being able to manage care. So even though they may not have that direct lever, it still impacts their budget and their performance. And I think it would be a good line of inquiry.
I did just want to highlight also, Dr. Kreider, you made the great point that the term providers may be overbroad. In that way, there's another way in which the term providers may be overbroad when we're talking about the coding intensity work, which is that this is one of the areas where, in particular, in some of our administrative complexity work, where we're seeing a real tension between providers at the system level and the frontline clinicians. Many of whom have been expressing concerns about some of the administrative burden of their EHRs and just the amount of time and effort that it takes away from clinical care. And so just as I think there's an important distinction, as you raised, between the independent providers and those who are part of systems, I think there's also a real tension between the clinical staff and administrators on some of these issues too.
I know this analysis is focused on the inpatient side, but last year's cost trends report showed that outpatient spending was the largest growth category. And so do you think that the trends from the inpatient side have any cascading impacts on the outpatient spending trends?
Yeah, that's a really good question. I mean, one thing that's easy to observe there that we will also come back to is, for example, there's an increase in billing for the longer visits, the 99285s, the 99215s, and less of the shorter visits. And so that's an obvious example that you see. That's kind of professional / outpatient. We're looking separately at what's behind the outpatient increase. So we're looking for differences in breaking down those surgeries, for example, in different categories of care. But it's harder to see the acuity trend in the outpatient per se, because often those payments are just a fixed amount for an MRI or for a scan or something like that.
Yeah, we, as part of last year's cost report, we measured the increases in the proportion of the high severity ED visits. So that was like just one measure that was easy to measure. That also showed that every year there was an increase in those ED visits at a high severity level and a decline of those across all years.
The more we dig into this, the better, as far as I'm concerned. I've got two questions, and David, I think maybe we need to comment on this. So let's let's take off the table that actually this Commonwealth is getting sicker at this rate. That's just not possible. This is adjustments in coding, which is either a game that's unfair because we set it up that way, or it's a game which needs to be played because these places have been ripping them off. We haven't been paying them for the actual acuity. If it were true that we weren't fair in 2013 or 2012 with acuity and we're getting fairer now, then that should be reflected in better margins. The hospital should be covering costs that weren't previously covered. And so we ought to see some effect on the financial viability of these places, and now finally we're paying them fairly. I personally don't think that's going on. I very much doubt that. But is that logic right? Is that a question worth asking? The second question I have is back to David's policy point, which is how can we put a stop to this? I mean, this is hurting the Commonwealth in terms of total medical expenditure. It's being hidden, except in our benchmark, and it's not good for the Commonwealth if our target really is to control total medical expenditure. And I don't know what public policy debate says we have to go to global budgets and get out of the fee-for-service system completely. But I'd like to engage a conversation about what it would take to stop it.
Can I pick up on Don's comment, because my thinking was along the same lines. My sense is that much of this is real true conditions that were underreported previously and that are now being brought up because the coding software is better. And so they're just surfacing what was always there but not reported. And for many purposes, it's a good thing to have information about the past conditions of the patient and so on. That much said, it then shows up in higher spending for the Commonwealth. One of the interesting things is that I don't think, as best I remember the data from GIA, I don't think the profit rates are going up particularly. And so that leaves a couple of theories. One theory is that the payers are making it up on the average rate side. So they see that that the severity is going up 2% a year, whatever. They say, okay, fine, but that will limit how much we pay. And so they're sort of we're trading a kind of 3% rate increase for 2% rate increase plus money spent to upcode, which in terms of dollars paid out would be the same, but obviously the administrative costs of doing it the one way are immense compared to the administrative costs of doing it the other way. Or another possibility is that it really is making up for the fact that costs are rising more rapidly than the rates are, and that the rates are being held down, and so that in order to cover margins, what the providers are doing is sort of increasing the coding. But I don't know, and I think it would be valuable to come back to the earlier discussion about the margins to see what's going on. My sense is the margins are not exploding, in which case it would be something offsetting it on the cost side. I think but then to be careful, these things are, to think about how to get rid of it, these things are baked into so many things that you really need to, it's kind of like the weed with very long roots. I think we really have to go after, like, for example, it's the upcoding in terms of the severity in terms of measuring the performance on the performance improvement contracts. And it's the severity in terms of measuring which of 99215 versus 99214 is what and it's the severity in terms of the risk adjustment on the inpatient stay and so on. Just doing some kind of global payment doesn't solve that, because you could keep those in many of the global payment contracts have these things in them. And so you really have, I think we ought to really, really think about this, but it's going to be a lot of work. I mean, when I think about sometimes it's having a payment system that says, forget about all those small risk things. They're important to know in the record, but they're probably not important in clinical care and cost of care. And just think about the big ones and just say, look, why don't we just risk adjust the very, very big things that obviously have a huge impact, and then we can all save the administrative expense of paying Epic all this money that whatever. So I think we have to think about it, but all of this makes me think it's a bigger issue than I had suggested was.
I think the financials become a key play here. And I would agree. I doubt that the net margins have increased. But that doesn't mean these systems, especially the larger systems, aren't doing a lot better than they have. And assuming the coding is accurate, they've finally been able to code it accurately, they are definitely generating more revenue. And the question becomes, as that flows through the financials, where is it going? What are they doing with it? It's not necessary. I would doubt it falls down to the margins. It's happening above that. But that is something we really need to look at. Because as we celebrate hitting our numbers, the reality is, are we really hitting those numbers? Right? I think we really need to look at that. And David mentioned costs. Maybe costs are increasing. That's something we need to look at as well. I think this leads to, we need to perform a real analysis on the financials of the industry to see where the issues really lie. And I don't think at this point we know.
The cost hypothesis, David, is that their supplier costs are going up, and the only way they cover it is to recover. Is that what you're suggesting?
Yeah, so it wouldn't surprise me if some of it is going to, for example, payment for inpatient medications for which the reimbursement rate by themselves is not going up that much, something. I mean, I have no factual basis for that at all, which has never stopped me in the past from asserting anything with great certainty, but it could be something like that.
Commissioner Berwick, to your point, I don't think we're at a stage of what's a public policy solution. I think this is really, presenting this data for the first time here today is really to solicit a conversation and also to put it out publicly. And we are very interested in learning from stakeholders about your own perspectives on these dynamics. And please, we will reach out to you, but also feel free to reach out to us, because we are trying to kind of put together that full picture. And I would say, I don't want this to come across as being negative in terms of health status adjustment, because health status adjustment has a very important public policy purpose around making sure that resources are going in the places that are most needed for the care of those patients, and that provider systems don't have incentives to avoid very sick patients, and that this is intended in some ways to avoid adverse selection. Provider systems would say that these systems are all imprecise, and even if we could code every single diagnosis, do they take into account the patient's social situation or social environment or other things that are going on that may impact the health and acuity and utilization of that patient? And so, understanding there's limitations to all of this and the way that these systems work. Nonetheless, the trends that we're seeing and the impacts that we're seeing are, I think, raised to me a line of inquiry that is important for us to continue to pursue. And I feel like I'm getting some support from the commissioners to continue down this path.
Can I pick up on one thing that Ron suggested, which I think might be very useful? We could certainly do some kind of overall but financial analysis of the hospital industry in Massachusetts. So we could do something on how fast our revenue is going up from different payers, and then in aggregate, how fast our costs going up from different payers, and in aggregate. And we can try and put this into that picture and say, well, okay, how much is this on the revenue side? And therefore, what would be the gap between the revenues and the expenses if this changed without anything else changing? Or what is this doing to offset other costs? Or something like that. We could try and put this in some number with respect to the overall hospital industry. I think would be quite valuable.
And I think, David, something that we haven't talked about yet, that you alluded to, is to the extent that coding is used to do clinical research. If it's fabricated, then any policy development we do, or any research we do around clinical practice issues becomes skewed. And so it's not real data, and that has serious implications for the clinical research component of all this.
Another interesting point is, if I look at it as business, and do I prefer to have patients, or should I call them clients, customers, at severity level 3, 4? That's something I would look at if I were running a business. Where do I want to focus?
David, since I'm in this company here, I know you don't want to get to policy implications yet, but I've got to raise something for you here. If you really wanted to work on making sure that money got to the places where it needed to take care of the patients, yes, you'd do adjustment for patient's acuity, but social determinants would become an adjuster. You'd actually be, and that's what they do in the UK. You know, there's a area deprivation index, and the total English National Health Service budget is reallocated among areas according to social deprivation. There's a very rational policy, and that's actually not just not done in this case. It may actually work in the wrong direction because the really high clinical acuity patients aren't going to be in the deprived rural or community areas.
And I would give a hat tip to our colleagues at Mass Health because they have begun to incorporate concepts of social determinants into their risk adjustment tools with the Mass Health ACO program, and they're leading the way.
So if we could look at that, it would be great.
Martin. This is either absurdly complicated to study and costly to study, or we try to find simple ways to get to good enough information, proxy information. Since we have been discussing general and administrative waste and general and administrative expenses for both payers and providers, I think it'd be pretty simple to ask them for headcounts and what their headcount distribution is. For the payers, we'd see a huge rise in case management that at least most studies show don't generate a lot of return on investment. For the providers, we'd see a lot of increase in coders. But when we layer systems into industries, the idea is to automate certain processes and become scalable in the process. And it doesn't look like there's any scale or economies of scale and efficiencies happening here. And so let me ask if you, David, or somebody on the staff, put a call in tomorrow to one of the big systems and to one of the big payers and say, we know you have 11,000 employees, or we know you have 65,000 employees. What's the headcount mix? Separate out those that are delivering clinical services from those that are delivering administrative services and get a break. They have a breakdown of who's doing what. Do we have that ability? Why would that be a costly and time-consuming process? I think it would give us pretty good proxy information on where the administrative waste is.
I think we absolutely have the ability and authority to ask. What we may not have is the authority to compel an answer. Although there are many providers and health plans in the room here, so we could potentially call on some people and see if they'd be willing to volunteer. I think this could be a really great data point for the cost transferring. So I will make a commitment to see what we can do in terms of being able to put some numbers to this, talk to a provider, talk to a health plan, and be able to use that as perhaps some additional context for this conversation in October, if that sounds reasonable.
The current population survey could also give us tabulations of occupation by industry, so we can know what are all the detailed occupations, administrative worker, which type, say the hospital industry.
Great discussion, but I'm going to move us on.
Yep.
Thank you. We now have a report on some publications that the Commission will be issuing. David?
Great. So switching now in the agenda, we're going to have two quick kind of presentations on two recent publications. These are both publications that have been released by the HPC. Both of them came out during the summer in August. And so wanted to use this opportunity to present some of the information to you, the board, and get any feedback you may have, but also to let the public know about these two new data sources that were on our website in mid-August. So the first is a topic that we have spent, has been a huge priority for the HPC since for at least the last 5 years, which is talking about the issue of out-of-network hospital billing. And so I'm going to turn it over to Kate McCann, who is our in-house expert on everything out-of-network surprise billing, and to walk through this new publication that we put out a couple weeks ago.
Great, thank you, David, and happy to be here this afternoon. Good afternoon, commissioners. So happy to be here to discuss the HPC's most recent issue in our data point series, which, as David said, we published in mid-August. It's available on our website. So happy to formally introduce it to you here today. Out-of-network billing, or surprise billing as it's sometimes referred to, continues to be a priority policy issue for the HPC. And candidly, it remains a very pressing and timely policy topic around the country on both the state and federal levels as well. So as is well known to this audience, the HPC has consistently recommended comprehensive state action in this space to enhance out-of-network billing protections for Massachusetts consumers. And those recommendations include the establishment of a process for fair and reasonable reimbursement to providers. As a brief reminder, this particular policy issue is multifaceted. There's a significant consumer protection aspect to it, as well as important implications for overall market functioning. As a reminder, we're talking about situations where patients did not or could not intentionally choose to receive care from an out-of-network provider. That predominantly happens in 2 scenarios, the first being emergencies, and the other scenario being a case where a patient elected to go to an in-network facility. And while they were there, during the course of treatment, they were unexpectedly treated by an out-of-network provider. So given those scenarios, comprehensive solutions to this issue limit patient liability in general and prohibit providers from balance billing the patient in those scenarios. And around the United States, in recent months and years, efforts to address this issue have really notably increased in intensity. And those efforts really do reflect a general consensus to protect the patient and, quote, remove them from the middle. You'll hear that term a lot. So while protecting the patient is a principal component of a comprehensive solution to out-of-network billing issues, the focus of the data points and the presentation here today is on the remaining question that results, which is what is the out-of-network provider paid for rendering those services? And to put it candidly, this is a significant challenge. It is the question of what constitutes fair and reasonable payment and how that's determined are questions about which perspectives can vary considerably. At the core, there's sort of a central, very complicated balancing of interests between the providers and the payers. And even with momentum and interest in solving this and protecting patients, around the country as legislative proposals are debated, the question of provider payment has sparked great conversation, great controversy, and has caused legislative efforts in some instances to fail. At the same time, lots of states are tackling this and have managed to get something passed. So payment benchmarks have become central to this question of out-of-network provider payment. And benchmarks can be used in both of the primary approaches that have really arisen in this setting. So one approach is to set a default rate. And in that scenario, the benchmark is the prescribed payment level, or perhaps a floor, a minimum payment. The other primary approach is to establish a dispute resolution process or program. And benchmarks can also be incorporated into that process, whereby the independent third party whose task it is to determine what's the more reasonable payment or what is reasonable payment could rely on benchmarks as a reference point in making that determination in a particular situation. So data points issue number 14 builds on our prior work in this out-of-network billing space. And the data points uses data visualizations to illustrate the range of payments associated with various potential benchmarks for a set of services that are often involved in surprise billing scenarios. Any questions before we move to the next slide? Questions on background or where we came from? So in terms of our research methods, the data points issue considers the fact that proposed surprise billing benchmarks are typically based on one or more of three different payment types. Charges, which are non-discounted full provider list prices, if you will, negotiated allowed amounts for in-network providers, and Medicare fee schedule rates or a multiplier thereof. So we publish new data obtained from an independent database that I'll explain a little bit more in a minute. And these data are objective and can contribute to the evaluation of the impact of various payment benchmarks that have been proposed or may come under consideration. So there are certainly others, but the 6 payment benchmarks we analyzed are relevant in the conversations in proposals and or other laws in this topic. So we published data on 6 potential payment benchmarks for each of 6 procedure codes. And the particular procedure codes in the data points were selected because they're more likely than others to occur in surprise billing scenarios. They also involve what we call ERAP providers, that's a term you've heard before. Those are the emergency, radiology, anesthesiology, and pathology providers. And those are common providers in these scenarios. In order to publish this analysis, we worked closely with an organization called Fair Health. Fair Health is a national, independent, nonprofit organization. They claim to be the nation's largest database of private health insurance claims data. They were established a decade ago, and their mission is to increase transparency around healthcare costs and insurance information. And Fair Health data is used for a wide variety of purposes. It is by no means limited to the out-of-network billing space. But in the last few years, Fair Health has also been featured in many conversations on this topic. This is in part, for example, because New York and Connecticut, who both passed what are considered to be fairly comprehensive laws to protect consumers and address this issue, they both designated Fair Health as their official benchmarking database in order to implement those laws. And just as another example, New Mexico passed a law a few months ago. They too have selected Fair Health as their benchmarking database. So it's become sort of centralized in the conversations, and we have heard a lot about it. So we endeavored to obtain Massachusetts claims data from Fair Health for this analysis in order to present some new data that hasn't been presented before. So on the next slide, I'll show 2 charts for 2 of the procedure codes that are in the data points. The others are available in the data points, which again is on our website. But before we get to 2 of the charts, we'll have the ball. Here are the takeaways from the analysis, and you'll see these represented on the next slide. The analysis really highlights the health provider payments would vary under different potential payment benchmarks. And you will see wide variation. There's significant variation overall among the different benchmarks. With those based on charges, typically 2 to 3 times higher than those based on allowed amounts or Medicare rates. And this underscores the fact that in considering policy solutions to address out-of-network billing, it's very important to consider the impact of the different potential payment benchmarks, for example, on overall healthcare spending, or a benchmark to be established. So here are 2 of the charts presented in the data points. This is not an interactive tableau demonstration for today's presentation, but there is an interactive feature on the data points itself. You can toggle between the procedure codes. To orient you, what you're looking at is 2 of the procedure codes we published data for. On the left, there is an emergency procedure code, so that's the E and ERAP. It's one example of an emergency procedure code. And on the right-hand side, the chart reflects an anesthesiology procedure code. In each chart, you see 6 orange bars, and those represent the 6 different payment benchmarks. There are, of the 6, those are really 3 sets of different types of payment, as I described at a high level on the previous slide. So they're based on charges, allowed amounts, and Medicare rates. So in more detail, the leftmost 2 bars, or benchmarks, are based on charges. The very leftmost bar is the 80th percentile of charges, and just to be clear, the 80th percentile here represents the 80th percentile of the distribution of charges in Fair Health's database, meaning that only 20% of charge values are higher than that number you see there. And the second charge-based benchmark is the median charge, so that represents the 50th percentile. The middle two benchmarks are based on allowed amounts. Again, those are in-network rates for providers that have negotiated and are under contract. Fair Health uses an imputation methodology to come up with those numbers, but you see those are labeled as 125% of the median allowed amount and the median allowed amount itself. And then the final two benchmarks on the right-hand side of each chart are 125% of the Medicare rate and the Medicare rate itself. And again, these are used in other states and or seen in other legislative proposals. There are other benchmarks that are relevant in these conversations, but these were selected because they're common in this space where solutions are being considered. And all of these data are presented at the level of statewide average. There's some geographic data in the data points, that's different, but all of these orange bars are at the level of statewide average. So for these two procedure codes, you can see the wide variation in payment benchmarks. Taking the emergency procedure code on the left, you see that payment at the 80th percentile of charges, which is $842, would be 3.5 times higher than the median allowed amount of $241. And a benchmark set at 125% of Medicare for this procedure is $233, which would result in a payment just below the median allowed amount, which in this case is $241. So in this case, those two amounts are very similar. In the anesthesia procedure code, the 80th percentile of charges payment level would result in payment approximately 2.5 times higher than the median allowed amount. And in this case, that median allowed amount itself is nearly 3 times higher than Medicare. So the distribution between the 80th percentile of charges here and the Medicare rate is much higher. It's about 7.5 times. So the takeaway here, and I'm happy to take questions, but the takeaway here is really that we're excited to publish this data. It's new data that's relevant to the consideration of potential out-of-network billing solutions. It highlights the variability in potential benchmarks and supports the importance of considering the impact of these benchmarks in evaluating and considering potential solutions for Massachusetts consumers and thinking about the effect on the overall healthcare market as well.
Great, thank you. So our next quick hit here is going to be a topic that we haven't talked about at a board meeting in a little while, which is our chart investment program. So the chart investment program, as you all remember, was our signature investment program that we launched as an agency at the very early inceptions of the agency, and followed up in Chart Phase 2 with our most significant round of investment of $60 million in community hospitals. The program came to a close earlier this year, and so we've really been in the process of now being able to take all of the data and information we've learned and really try to understand more about what was the impact of this investment. There is always a little bit of a time delay from when the program ends to when you get the data to when you can analyze it and evaluate it. But nonetheless, we're really excited to be able to start talking about the tremendous impact that this program had, both on hospitals, but also especially on patients in the Commonwealth. So to give a few highlights from a recent document publication, I'm going to turn it over to our new Senior Director for Healthcare Transformation and Innovation at the Health Policy Commission, Kelly Hall. We're very pleased to have her join the organization. She's been with us for about 6 weeks. And so we'll want to turn it over to her to just walk through some of the key findings from this new brief that we put out.
Thanks so much, David, and good afternoon, everyone. I wish I could take credit for this good work, but I will do my best to at least report on it well. So I am pleased to be here today to give you, as David said, some highlights of the CHART program impact brief, which is a high-level document that's intended just to summarize some of the key findings. And what I'm going to do today is not even attempt to dive into everything we learned, but to just give you a flavor of what you will see in the impact brief, which is available now on our website. So one of the explicit objectives of the CHART program was to make investments in workforce, particularly to promote the notion of interdisciplinary care. I think we can see from these data that the program was quite successful in that regard, in that 53% of CHART budgeted dollars were allocated towards personnel, with particular emphasis on behavioral health providers, nurses, and community health workers, in addition to some more unusual investments, including music therapists and other staff that health systems felt would contribute to whole person care. There were also investments in existing staff in non-traditional ways, including pharmacists who conducted home visits. Oops. Gotta go back. So there really were 4 critical goals related to the CHART program: delivering integrated care across medical, behavioral, and social needs, keeping care in the community, using data and analysis to better serve patients, and ultimately to align all of those things towards preparing health systems to participate in value-based care models. Without diving too deeply into all these data points, I think it's safe to say that significant progress was made against all of those goals. Just some highlights: 81% of hospitals instituted new staffing models or processes to integrate care. We saw substantially fewer ED visits in CHART hospitals. 24 of the hospitals invested in a case management platform to track target patient populations and measure services. And 76% of participating hospitals reported that CHART facilitated a broader hospital culture change that helped prepare them for value-based care. So, in one of the more interesting metrics, we also saw that 20% of awardees met or made significant improvement towards their target aims, such as reducing ED revisits among high utilizers or across behavioral health diagnoses. So we're really, really proud of these results. If this is interesting to you and you want to see more like it, definitely visit the website. But in the midst of all of these analytics, I don't want to lose sight of the real goal of this program, which was to make meaningful improvement in how patients were served. I'm not going to read all of the details of this graphic to you, but it represents a not unusual story of a patient with diabetes and multiple complex issues who was largely disconnected from the ambulatory care system and was using the ED for care. For this patient, the multidisciplinary team at Signature in Brockton connected the patient with primary care and a range of other community-based services to support her in her treatment. The good news with all of this is the team did follow up, and the patient has managed to continue on her care plan and stay out of the ED. So there are numerous stories like this coming out of the CHART program, and we feel really good about knowing about that level of impact with individuals. So as I said, if this is of interest to you, there is more information like this coming. The impact brief is one of several outputs that we'll be producing over the next several months to capture the impact of CHART. You can expect to see CHART playbooks, which are a compilation of lessons learned, resources, and tools from CHART awardees. We're also developing profiles of each of the CHART awardees that highlight the specifics of their care models and provide key data highlights. And then ultimately, we will be releasing the full evaluation of the CHART program later this year. So definitely more to come.
Yes, congratulations, Kelly. It's great, great outcomes and welcome. I guess my question is, with these kind of outcomes and the lessons learned, we can put it out in our publications, we can put it on the website, but are there other next steps that we could take that would further disseminate this more actively on our part into the broader community, and how might we consider doing that?
Yeah, I think that's a really good question, I think. Taking these learnings and doing exactly what you described, just developing an intentional strategy for both learning and dissemination will be a critical follow-up step. I don't think we've got that completely figured out yet, but it's definitely a conversation.
I wonder if part of the conversation we might include not only the providers, but also the payers. And having the payers rather require or consider requiring some of these steps as part of the process, especially with chronic diseases. Diabetes is an incredibly complicated disease to manage. Primary care providers have difficulty with it, and we're asking patients to be competent and expert. It's in the insurance company's best interest that those patients get to do that. And it's in the patient's best interest that they get to do that. And so thinking as broadly as possible is how do we engage and create the expectation from a variety of different resources that becomes part of the goal is how do we help what we've discovered to work to move towards the standard of care? And can we consider that?
Absolutely. Questions?
Kelly. So, well, we still have more. So now I'm going to move to our final research presentation of the day, our final new set of data and information that we're excited to share with you. Again, you're sensing a theme here. These are our preliminary results of a new study on the impact and utilization of drug coupons in the Commonwealth. And we'll have the team talk a little bit about what we mean by drug coupons. But again, this is an opportunity. We don't have all of the analyses prepared for you today, but wanted to start this conversation. Again, any feedback or direction about where to take this next. We do hope to compile this into a report that would be available this fall. So we are working actively hard to finish this important piece of work because it does have an important relevance to the legislature and the administration in thinking about the policy around drug coupons. So with that as just a very brief introduction, I'm going to turn it over to Sarah Sadownik, who's going to lead this presentation of the new preliminary results from the drug coupon study.
Thanks, David. Okay, so as David mentioned, we're going to be presenting part one of our work today. I'm going to start out with a brief background to get us to where we are today and why we are engaging in this work. So in 2012, the legislature allowed these drug coupons for the first time. There were two important provisions in this law. The first is that although coupons were allowed for the first time, coupons continue to be banned, and that's the case today, for drugs where there is a direct AB equivalent of a generic. And also provided for a sunset provision. That sunset provision has been extended, and in the Act of 2018, Chapter 363, that law addressed drug coupons again, delaying the sunset until January 1st of this coming year, and directing us to study this issue. So this is, again, a summary of what we have been charged to study. We've been charged to study a number of aspects of drug coupons, the total number, the value, what they're for, and then how they might impact patient choices of what drugs they use, in particular the utilization of generic alternatives. Again, that's not the direct equivalent, but an alternative generic that they might use, as well as an alternative brand, as well as effects on patient adherence, access, availability of coupons, and then total systems. So defining drug coupons for our purposes, what we're studying is drug coupons that are offered by manufacturers for patients with commercial insurance that reduce the amount of a patient's cost sharing. This is for branded drugs
And the patient's cost sharing is set by their plan. For example, the patient may have high cost sharing on this particular branded drug, perhaps to steer patient incentives to a different choice, or they might have high cost sharing for all of the many branded drugs. This type of coupons that we're talking about are distinct from other types of programs, distinct from patient assistance programs that may be offered by manufacturers or states or charities for patients on the basis of affordability of their income. Also distinct from coupons or discount cards that reduce prices for patients without insurance. And just a note that public payers, Medicare, Medicaid, the VA, do not allow the use of coupons at all. This falls under the anti-kickback statute. We have some examples here that might look familiar to some folks. This is a chart that illustrates the flow of how coupons work in practice. We've shown this before, so I'll go through it quickly, but I think it's always a helpful reminder. So in this case, the patient is responsible for cost sharing of $610. This is a theoretical example for their drug. So the manufacturer offers a coupon, perhaps it's online in a doctor's office. So let's say in this case the coupon is worth up to $300. The patient obtains the coupon, brings it to the pharmacy to pick up their prescription. They have a liability exposure of $610. They give the $300 coupon and they pay the balance in cash, $310. They get their prescription. The pharmacy reports to the plan that the $610 responsibility was met, and then the plan reports $610, for example, for the patient meeting their deductible against their deductible. Okay, so for our research, we've drawn, continue to draw on a number of sources: literature, public listening session that was held in May, data from the All-Payer Claims database, as well as a data set from Symphony Health. This is a data set that we obtained from a national data services vendor. This database contains transaction data at the pharmacy, at the point of sale at the pharmacy. That data includes data from all payers in Massachusetts, all the data that's in Symphony's database. It's a subset of all claims in Massachusetts through the years 2011 through 2018. This is a particularly rich data set that has information on plan payments, patient out-of-pocket spending, coupon use, a lot of detailed information about the drug. So just to kind of put into perspective what kind of sample we have, the database has claims for 1.1 million unique commercial patients in 2018, and we've estimated what that comparable number would be based on GIA data for people using at least one pharmacy claim in Massachusetts. Okay, so today we're going to focus on our results for the first question in our charge. This is an analysis of the use of coupons, value, what were they for, what does the market look like in Massachusetts, and the presentation of our results for the additional questions will be at our next presentation. And we'd also like to use this as an opportunity to get your feedback on these results. And to start us off with the presentation of results, I will turn this over to my colleague Eva Wang.
Good afternoon, commissioners. Okay, so we have a number of statistics on the slide, but together they give a picture of the current coupon use in the state of Massachusetts. So on the left, you can see that in 2018, our data show that 3% of commercial patients who fill the prescription used a drug coupon. So again, we are just talking about manufacturer issued prescription drug coupon here. We're not talking about discount cards that are, for example, issued by pharmacies or other third parties. We're also not talking about copay assistance programs run by charities, for example. So these are just manufacturer issued prescription drug coupons. And that share does seem like a small number, but to put it in context, we know that 90% of all prescriptions dispensed on average in the US is generics. And among brand name drugs, we know that in Massachusetts, coupons are not allowed on brand name drugs that have a direct AP-rated generic. So we are talking about a relatively narrow pool of eligible drugs here. Okay, so for people who did use coupons in 2018, you can see the statistics on the right. They used coupons on 3 claims on average, and the average coupon value is $229 per claim. That average is a pretty high number, but it is certainly driven by a small number of coupons that are high value. So let's look at the graph below that shows a more typical patient experience that's more modest. So the graphic below shows the distribution of coupon values in 2018. So you can see that the 25th percentile is $30, so that means a quarter of the coupons are less than $30. The 75th percentile is $150, so that means there's a quarter of the coupons that's more than $150. So if you put those two data points together, that shows that half of the coupon fall between these two values, $30 to $150. In fact, the median is $55. Of course, there is a small number of coupons that are worth very high value. You can see that here the 95th percentile is over $800, so that means there's 5% of coupons that are covering $800 or more of the patient's cost-sharing liability. So to put that in the perspective of how much that's helping patients, we calculated that for these brand name drugs where a coupon was used, patients would have been liable for about 21% of the cost of the drug. So with these coupons, patients are left paying about 3% of the cost of the drug. So certainly it's providing a huge relief for patients that are taking advantage of these programs. So those are statistics from 2018. We also looked at trends over time. And by a number of different indicators, coupon programs and their use have been expanding in the state of Massachusetts. So the blue bars here show the average coupon value. And you can see that in 2012, it was less than $100 per claim, and that has more than doubled since then. In 2018, that number is $229 per claim. And not only are the coupon values growing, the number of brands that offer these programs are also growing. So all the way on the right, we show the number of brands that offer coupon programs in Massachusetts. So in 2012, the first year coupons were allowed in the state, there was 278 brands that offered these programs. And in 2018, that number has risen to 700 brands. And this growth is pretty consistent from numbers we've seen in terms of national trends that have been reported elsewhere. In addition, the adoption of these programs is also going up. So the numbers in orange show the percentage of eligible claims using a coupon, and by eligible we mean a brand name drug that doesn't have a generic that's eligible for a coupon in Massachusetts. So we see here that in 2012, the coupon penetration rate is about 2%, and that has gone up to over 15% in 2018. So the offerings are growing, and the patient use of these programs are growing as well. Hand it back to Sarah.
Okay, so this graph shows the patient experience of out-of-pocket costs for all branded drugs, those that do, and also including those that don't offer coupons as all branded drugs. And what these lines
what these lines are depicting are what the patient is responsible for, what we're calling their out-of-pocket exposure, and what they actually paid out of pocket after any coupon use. Again, averaging claims that did and did not use a coupon. So let's start at the gold lines at the bottom. This is all branded drugs. The solid line shows patients' initial out-of-pocket exposure, growing from $29 in 2012 to $42 in 2018. So some increase there in average responsibility. The dotted line shows actual out-of-pocket spending net of any coupon use. That number has held fairly consistent over this time period, and is providing some benefit to patients on average. In 2018, the difference between $42 and $28. However, if we now turn to the lines in dark blue above, we see a very different set of trends. These lines show trends for patients with high out-of-pocket exposure, which we've defined as more than $50 per claim. So they're responsible for more than $50 for that prescription, for that branded drug. And what we see is that for those patients with high out-of-pocket exposure, what they are responsible for paying has doubled over this time period, $96 to $186 in 2018. And we see that coupons really have the largest benefit for these patients. So comparing the solid line to the dotted line here, we see that actual out-of-pocket spending has grown, but has grown more moderately. And in fact, the wedge has also been growing. The sort of the added value to patients has been growing over time. So in 2018, factoring coupon use, out-of-pocket spending was 44% less per claim than what they were responsible for, what they actually had to pay. So there's a lot of factors that are combining to result in these trends. So one thing that's just sort of one important factor, one important takeaway here is that in people with high out-of-pocket exposure, we know that each coupon both has higher value on average, and coupons are being used more often. We can talk about some of those numbers. Okay, so now let's turn to what coupons are most frequently being used for. Here we have the top coupon drugs by total volume and the top therapeutic categories. I'm going to start with the therapeutic categories on the bottom graph of the slide here. So we see that the top category is diabetes therapy, including insulin, at 20% of all coupons are for this category. Next is antivirals, predominantly HIV, antiarthritics, respiratory therapy. This is mostly inhalers, asthma, COPD. Hemostatic modifiers. This is mostly blood thinners, such as to prevent stroke. Psychotherapeutic drugs, dermatology, and others. So as you can see, these are mostly for chronic conditions. So turning to the top actual drugs in the table at the top. So there's a lot of information here. I'll walk through kind of what we have. So there's the drug name, the therapeutic class, conveniently color-coded to the categories below. The number of claims using a coupon. Remember that this is a subset of all claims in Massachusetts. The percent of claims for that drug that use a coupon, and then when coupons are used, the values relevant to those claims. The average value of the coupon, the average patient out-of-pocket spending after the coupon, and what the insurer paid for that claim. So walking through a few of these, the number one is Truvada. This is an HIV drug. This is PrEP for preventing or reducing the risk of HIV. infection, as well as used in treatment in combination for HIV treatment. 40% of these claims use a coupon. The next is Trulicity, a drug for managing blood sugar for type 2 diabetes. Here we see 26% of all claims use a coupon, and then just wanted to highlight sort of how these numbers work together. The average coupon, for those who used a coupon, the average coupon value was $41. The remainder was $32. So basically, in those cases, patients were responsible for $73 cost sharing, but only ended up paying $32 on average. Suboxone, we want to highlight that this is for the type that dissolves on the tongue that did not have a generic at this point in time. And then Humira, I won't read all of these, but I'm just pointing out some sort of interesting notes. So, and here we see 76% of claims used a coupon. We tend to see, we have tended to see higher coupon use for drugs that are more expensive. There are a number of exceptions, but that's kind of a general finding. And then I'll just highlight the 10th at the bottom, 1 brand of insulin that had low coupon use at only 8% of claims, but those claims that did use a coupon had a particularly large benefit. So basically, $123 of savings from that coupon, and on average, almost no patient spending after that. So we wanted to keep this kind of very focused on kind of the most important key findings, short and sweet. So in summary, coupon values vary widely. This was an average of $229, but for most people who used a coupon, the value is smaller, maybe at $55. We have seen a very large expansion in coupon programs and their uptake since their start in 2012 in terms of the number of brands and patients using them. And we have seen that coupons have the greatest benefit for patients with high out-of-pocket exposure. So we are looking forward to presenting our full presentation next time with results that will particularly highlight the impact of coupons on total spending and answering the question of do they raise spending by impacting patient choice of drug and benefits to patients of adherence, among other questions. So I'll pause there and look forward to any questions.
Question. Do you have a sense of the prevalence of drug coupons for non-chronic diseases?
It's a great question. I'm thinking about how to answer it. The top by volume are for chronic conditions, and that makes sense given the volume of claims. It's for the next time, I'd like to think more about how we might define that. There's a lot of kind of the best way to present that. There's a number of different types of drugs that might fall into that. For example, that vary a lot based on what the indications were for the price. We know EpiPen in these years was in 2018 it was 15%, but for Harvoni, for example, was a much higher percentage. Obviously a much more expensive drug. So we'll think about the best way to summarize that.
Yeah, I'm just thinking like to hypothesize. I would think that from a business standpoint, it would not be strategic to offer these coupons for drugs that are for episodic. So I would just be interested to see what their preference is, if at all.
Great, thank you. So more to come on that at the next MOPE meeting. which is scheduled for October 2nd. And again, we'll focus on some of the spending impacts and adherence impacts there. So just a few final agenda items today for the meeting in my executive director's report. Before I jump into that, though, I do want to just make sure that I have put something on the record here in this public meeting. Our contracting with Brandeis to help us conduct some evaluation work, and so important for me to just state on the record what that process was. So for our targeted cost challenge investment program, which was underneath our healthcare innovation investment program, we identified a need to bring in a vendor to help us synthesize and write up the evaluation findings and to help prepare our final report. So we did conduct a competitive procurement process, and we selected Brandeis University to help us conduct this work. And I would just note that Dr. Altman, who was a faculty appointment at Brandeis, was not involved in this procurement or the selection of this vendor. Thank you. All right, so some final things to talk about. Do want to just spend a minute here to talk about the cost trends hearings. So we are in active gearing up phase for our signature event of the year. As you can see here, the save the date, we do have some postcards. Feel free to share it with your colleagues. And we are already registering online. For those of you who have attended in person in the past, you know that it is a completely packed room with many overflow rooms. So register now to be sure to get on the list. The agenda is not finalized, but is shaping up. So here on slide 70, you can see where we are today in terms of thinking about both some speakers and some thematic areas of potential focus. So starting on both days, really pleased to report that Governor Baker, Speaker of the House Robert DeLeo, Attorney General Maura Healey, and Senate President Karen Spilka are all confirmed to attend and provide remarks on both days of the hearing. So really appreciate the support and participation of our top elected officials in this area, and look forward to hearing their perspectives on healthcare cost growth in the Commonwealth and some potential solutions to that. On day one, we will have a robust presentation by Ray Campbell and David Auerbach from our team with some new findings that we will have both on the state's performance against the benchmark, but also around some affordability challenges that we're observing for residents struggling with rising healthcare costs. The two thematic panel ideas that we're circling around for day one are really focused on some of the bigger cost drivers that we observe in the data. So if you think it's a right conversation to talk about some of the hospital trends that were a big part of the conversation today, and to be able to have people who are in the industry be able to provide their perspectives and insights into what's driving some of those trends and what some mitigating solutions may be. Secondly, we still continue to see increases in the pharmaceutical space. And so again, believe this is another area where a conversation with stakeholders through the cost trends hearings could really help surface some solutions. On day two, a little bit of a different focus in terms of some new innovative ideas and techniques to try to improve the efficiency and the quality of our healthcare system. And so first, we'll have a panel focused on state solutions to strengthening primary care and behavioral health care. And we're pleased to have confirmed Marie Gannon, who is the Health Insurance Commissioner from the state of Rhode Island, and Chris Kohler, who is the president of the Milbank Memorial Fund. Rhode Island, as well as many other states that Milbank has been working with, are testing new innovative ways of trying to set targets for increasing investment in primary care. So we want to hear a little bit more about those strategies and if they may be appropriate in the Massachusetts market and how we can learn from other states. And we'll have a panel reflecting some of our local stakeholders to really dive in deeper on ways that we can really transform primary care for the future. And then finally, a topic that has been a thematic priority for the agency this entire calendar year is around reducing administrative complexity. And here too, we see an opportunity to bring a diverse panel together to talk about both the challenges here and where our solutions may be. So looking forward to a great 2-day hearing, and hope to let providers and health plans know imminently whether we would seek to have participation in the hearings on these panels. Any feedback or questions on the where the preliminary agenda is shaping up to be? All right, seeing none. So the final part of our board meeting today is just to talk about the fiscal year 2020 budget, the state budget, which was approved right before our last board meeting. As you may remember, I think it was the Monday before our Wednesday board meeting, and so we had decided to table a conversation about the state budget until today's meeting. So first, I just want to walk through some of our new responsibilities that are detailed in this new budget at a high level, and happy to kind of have questions from commissioners on this. But importantly, the budget contains really new important authorities and responsibilities for both, Mass Health and the Health Policy Commission with respect to drugs and pharmaceuticals. For Mass Health, this includes the authority to negotiate directly with pharmaceutical manufacturers for supplemental rebates on high-cost drugs, and for the HPC to potentially play a role in reviewing the value and pricing of these drugs if an agreement with Mass Health on the supplemental rebates cannot be reached. So the next part of these slides is kind of walk through this at a pretty high level. So first, just a little bit of background on the context of rebates in the Medicaid program. So the Medicaid drug rebate program, which was passed by Congress about 30 years ago, requires drug manufacturers to pay a rebate for all drugs dispensed to Medicaid beneficiaries. The amount of this required rebate is set by law, such that the net price of the drug is equal to either the best price available in the private market or equal to a certain percentage of the drug manufacturer's average manufacturer price, whichever gives Medicaid essentially the lowest price. And the percentage of the rebate federally does vary by drug, with brand names requiring the greatest rebate. Additionally, though, states have the authority, and Massachusetts has the authority, to negotiate additional rebates on top of the federal rebates. And these are conducted at the state level, and again, may be paired with a placement on a state's preferred drug list as part of these negotiations. So the new authority gives Mass Health the direct authority to negotiate supplemental rebates on all drugs, but has a specific longer and more in-depth process for drugs that are categorized as high cost. So in the budget, these are the two key definitions of what constitutes a high drug. A drug whose post-rebate cost per utilizer is $25,000 or more, or a drug whose post-rebate aggregate cost to Mass Health is $10 million or more. So you can see here that this is really trying to get at two different scenarios. One is where there is a very high-priced drug that may not be utilized by a large number of patients, but nonetheless individually is very high cost, over $25,000. Or in the case where there is a drug that maybe has a lower list price, but is utilized by a great number of Medicaid beneficiaries, such that the aggregate cost of the program is above a certain threshold. So briefly on the Mass Health process, as I said, gives the direct authority to try to negotiate these supplemental rebates with the goal of really maximizing value for the Commonwealth. If Mass Health is unsuccessful or unable to successfully conclude those negotiations on certain of these high-cost drugs, they have some new authorities. So they can identify what they think the right proposed value of the drug can be, and then they can further solicit information from the manufacturer, can solicit information from the public, potentially hold a public hearing. And after considering all of this new information, the Mass Health can either revise what they think the appropriate proposed value of the drug may be, or engage in further negotiations. And if all of that is unsuccessful, even after going through that potentially public process and even further negotiations, Mass Health may refer the manufacturer to the Health Policy Commission for the next step of this review process. So this next slide then talks about what our authority here is. So first, our authority is triggered upon a referral from Mass Health. We do not have blanket authority to conduct these investigations on drug manufacturers. It really is contingent on a failure of successful negotiations, an identification that this is a high-cost drug, and a referral to the Health Policy Commission. So we then have the authority to solicit even more information from the manufacturer about the drug, the value of the drug, the pricing of the drug. We have the ability to develop, or a requirement to develop a standard form, which would collect some of this information. If, based on our review of all of that information, we think that the price of the drug is potentially unreasonable or excessive, then we can have the ability to require even more information from the manufacturer. I would note that much of this information we are charged with keeping confidential, understanding that this could be highly sensitive business proprietary information, although we can disclose some of it in a final report if it's balanced within the public interest. After reviewing all of that information, if the Health Policy Commission is then required to make a final determination within 60 days about whether the drug is unreasonable or excessively priced, and to report that publicly. So this is a really powerful, we think, new tool for the Commonwealth to be able to maximize value in the pharmaceutical space. This is a concept and model that has been inspired by what other states have done in this space, specifically New York, who has already been successful in being able to negotiate higher supplemental rebates through a more enhanced process, not dissimilar from this one. And so we really think there's a lot of urgency on the state perspective to move forward expeditiously but prudently in putting together exactly what this process is going to look like. So we have already begun this work. As soon as the budget was passed, we assembled a SWAT team internal to the HPC to begin thinking about the policy and regulatory development that will be necessary. As you can see from the statute, it does give us very clear direction, but it's also broad in some areas, so we're going to need to fill in some of those process gaps. We're going to need to create definitions, and it's really important for us to be able to do this in close collaboration with the Mass Health team and the Mass Health program, because they have a very complementary role here. While our role is as an independent and objective reviewer, nonetheless, it is incumbent on us to make sure that our processes are well aligned and working together, again, with the shared and aligned goal of maximizing value to the Commonwealth. So here you can see what we're thinking about in terms of a regulatory development timeline. Today, at the beginning of September, doing this initial presentation to the board, and we would like to aim to have final regulations done by January. So this is a quick timetable, but we think one that we can accomplish. And it does mean, though, that we will need to engage this board heavily this fall as we start to put more meat on the bones of exactly what our regulations and process will look like. We do think that the stakeholder community here is critically important for this work, especially in this development stage. So we're going to be reaching out to a broad, diverse group of stakeholders and experts and academics, other states that have worked in this area, really to try to learn about the best way to approach this particular responsibility. And we'll have proposed regulations that we'll put out for a public comment. Right now, under this timeline, that would be in November, and we would expect probably significant public comment on this, be able to incorporate all of that public comment, and then again, target being able to have final regulations done in January. This would allow our timetable to meet Mass Health's timetable because they are also moving forward expeditiously in this process. And I think that the soonest that we could potentially have a drug referred to the Health Policy Commission could be as soon as next February or March. So we need to have our process ready to go should that referral happen. That being said, obviously we don't know exactly what drugs or how many drugs may end up coming through to us in that referral process. Again, if the negotiations are successful, the Health Policy Commission may not have a role, but there may be cases where, unfortunately, the negotiations will not be successful, and we're going to need to be able to provide our quality work to help drive this policy conversation. So that was really high level and pretty quick, and I know it's at the end of a pretty dense meeting already, but happy to kind of talk a little bit more about how we're approaching this process or what the mandate is in the statute.
David, would we have the ability to look at pricing in other jurisdictions?
Yes.
David, assume for a moment we go through the process and we report out that we believe a drug is too expensive. Just to close the loop, what happens next?
So that is the end of the process as it's envisioned. Nonetheless, I think a determination by this Health Policy Commission with the rigor with which we conduct our work, that if this commission were to find that a drug was unreasonable or excessively priced, I think that determination would carry a lot of weight in the market and would, I think, strengthen MassHealth's ability and potentially other commercial payers to potentially negotiate for even greater rebates or for some modifications in that price. I may be optimistic in that regard, but I think if we do this well, this can be a powerful tool. As we've seen our other tools, even just a tool of transparency and reporting, having an impact on market behavior. So, but to be clear, it does conclude with a report out.
I hope you're not being too I really hope so.
Great. So two other things that were included in the budget. I'm very pleased to get some support from the legislature and the administration on two new grant programs, kind of investment, targeted investment opportunities. One is around thinking about substance-exposed newborns. This is an area that we have already done a lot of work through one of our grant programs, and this is really some additional money to expand the scope of thinking about where our current grant work is really focused on infants in the hospital and for the 6 months essentially after the hospital, after delivery. This new mandate envisions a little bit of a longer timeline and thinking about what are the supports for families and infants in these situations beyond just the initial 6 months, but potentially the first few years. And then a second new investment opportunity, which is something that is very timely in national health policy conversations and locally as well, around improvements in maternal health, and specifically in areas where there are maternal health disparities and inequities that are well documented. So I look forward to being able to work with the board to design exactly how best to target those monies for maximum impact. So the final agenda item here today is our HPC budget. So just really quickly, we did, the Administration and Finance Committee of the Health Policy Commission met prior to this meeting today for an hour and walked through a much longer version of the slides I will show here today, but did walk through our financial performance over multiple years as well as the proposal for next year. Not to speak on behalf of the members of that committee, but I think they were all felt confident in the approach that we were taking and the proposal for next year. But do want to walk through it very quickly for the full board because this is a vote to be able to approve our budget to move forward. So very quickly, the Health Policy Commission is supported financially by a number of different funding sources. So first and foremost, the biggest and most important funding source is our line item appropriation. This is set in the state budget. and is basically the maximum amount of the available funds for our main operations, payroll, consultants, rent, everything that goes into running this organization. That number is then fully assessed to hospitals, health plans, and to ambulatory surgery centers. We collect that revenue and deposit that revenue into the general fund, such that from the state's perspective, the operations of the Health Policy Commission are budget neutral. We have an appropriation, but then we also collect the revenue to basically offset that. We also, from time to time, get supplementary line item appropriations, and this slide that you're looking at here is the previous fiscal year. So what you're seeing here is the fiscal 19 summary of what we had available and what we spent. Last year, we did have some money for academic detailing. We're continuing to build that program and move that forward. And then our two other funding sources are our trust funds, which are really tied and linked to our investment programs. So this slide is just a summary of FY19. So this is the fiscal year that ended on June 30th. I won't walk through all of this other than to say in every one of these different categories, we were under budget, so feel good about that. In the cases in the trust funds where we're under budget, that money is retained in the trust fund and is available for expenditure in the following year. And again, this is a little bit of a time trend because there's all these different funding sources. We try to kind of put them all together. And from 17 to 19, you can see when you combine these different funding sources, the actual expenditures from the agency have been very stable. In the last fiscal year, we also do have a number of areas where we are partners with our other state agencies and help support shared priorities. Again, I won't walk through all of these, but to say that there are these, not an insignificant amount of our budget where we are working collaboratively with other state agencies and do help support that shared work. So that was the last fiscal year. Now quickly moving to the proposal for the current fiscal year. So slide 685 here is just a summary of the budget process. The most important box here is the final one in the dark blue. That is what we received in the final state budget. So you can see our line item of around $9 million. This was our maintenance budget request. And then the two new targeted investment programs, which were supported by the legislature and the administration. So again, thinking about those different categories. So what we're proposing for the next fiscal year from the line item is what was appropriated in the budget. We don't have a lot of discretion on that point, and it reflects a modest 3% increase from the prior year. We're going to have the new targeted investments, which I've already talked about, around $800,000. The Payment Reform Trust Fund is again linked to our investment programs. We've been deliberately designing a next round of investments, which we do plan to launch in the next fiscal year. So are requesting level funding to what we have requested last year, which we didn't actually totally spend, but we do think that we're going to be able to spend this year. And then finally, I do want to just spend a minute on the Distressed Hospital Trust Fund, because this is, again, expenditures that are tied to our CHART investment program most closely. And as CHART has winded down and as our investments have shifted a little bit more towards non-CHART hospitals, we have been ramping down the expenditures out of the trust fund related to those investment programs. So you can see that we're actually proposing a 52% reduction out of expenditures out of that trust fund related to those programs. And a big part of that reduction is the fact that two pretty significant evaluation contracts are closing. So our evaluation of CHART, which we contracted with the Boston University School of Public Health, is coming to a close, and our evaluation of a substance-exposed newborn program with the Department of Public Health, that evaluation is also ending relatively soon. So that does, we are not projecting a need to continue those contracts, and so that does free up some space for us. One extra level of detail here just breaks this down by a little subcategory. So on our main line item, we are projecting a slight increase in our payroll. This is not due to increased headcount. This is really a reflection of both some annualized costs as well as some costs that we're shifting off of the trust fund onto the line item. And in places where we're able to do things with employed staff that we had typically used contractors for. So we've been able to shift a little bit of the professional services. The next slide is basically the same breakdown, but for the Distressed Hospital Trust Fund, where we do have operating expenses out of. And as you can see, payroll is down. Again, that's the shift over to the line item, and the professional services is way down. And again, that's a reflection of the expiration of those two major contracts. So finally, just to give you a sense of the head count and FTE count of the agency, you can see here that we have been, on the top here, this is actual heads of people at the agency, and you can see that we've been relatively stable pretty much for the last 3.5 years in terms of total head count. When you look at it by an FTE equivalent, that can be a little bit different than the head count because we do have some part-time employees, but in this case is really exactly the same. So as of September 1st, we were at 59 employees, which is pretty consistent where we've been for the last 3 years. So wanted to reflect kind of where the employees' departments are. I would note too, the Care Delivery, Transformation, and Innovation Department is a new department within the agency that was a merger of two, what used to be our Care Delivery certification programs and our investment programs were separate departments. They've now been merged into one department. And so that's why that number jumps out. It's now our biggest department, but it was a merger of two smaller departments before. And if you add in kind of market oversight with our research and cost trends team, I think there's a really nice balance in terms of our two main policy priorities. You know, one, making the market work better, and two, really improving and transforming the delivery of care. And I think our FE counts and resources reflect that balance. So I went through that really quickly. Happy to jump in on any questions that commissioners may have. And would just say, I think as an opportunity to talk about both the fiscal health of the agency, but also just the overall culture health of the agency, I will report that the state of the agency is strong. And we are all excited to continue this work with you commissioners and with some of the new responsibilities that have been provided for us.
Good job, David. I'm surprised you still have a voice, having now done that twice today. First for the A&F committee and now again. But are there any questions first before I ask for a motion? Hearing none, is there a motion to approve the budget as presented? Second. Any further discussion? Not hearing any. All those in favor? Opposed? Motion carries. So the last bit of business is to the schedule coming up. So the next meeting of the commission will actually be a set of committee meetings, which will be on October 2nd here. The Market Oversight and Transparency Committee will meet at 9:30, followed by the Care Delivery Transformation Committee meeting at 11, and then following that, the cost trends hearing coming up in October 22nd.
Great, and I would just note for commissioners and for the audience that we do expect to have a presentation from our sister agency, the Center for Health Information and Analysis, on their latest report at those committee meetings on October 2nd. So mark your calendars for that. And I would perhaps note for commissioners, while it says here that the next full board meeting is not until December 16th, I'm afraid we may be in touch for some additional board meetings before then, given the plate of work that we have in front of us. So thank you, as always.
Thank you. There's no other discussion. A motion to adjourn. All right. We're adjourned.